Well, Dr. McCray, you've been joined by a dear friend of yours. Would you like to introduce your friend?
Yes, Sandy.
Hey.
Sandy and I go way back, but she can tell you her story. We met back when President Clinton had given us some money to do the Life Initiative called
Exactly.
Leadership and Investment in Fighting an Epidemic. I
Yes,
guess.
sir. I can't believe
And
you
so-
remember that.
Yes, yes.
That's impressive.
But she can tell you her story, but she has a long history in Atlanta.
Well, I'm going to do a brief introduction now. We're going to do a longer one later. Who are you?
Who am I? I am a Southern blonde from Atlanta, Georgia. I am an activist. I am an advocate. I am a social worker. I'm probably a fighter more than anything else, and sort of an relenting supporter of the people in the world. And
Well, your name is Sandy Thurman.
it is
Right? And Sandy Thurman, you've done a lot of things that a lot of people don't know. I think you have a relationship to a couple of A Club here too, and I think that we really need to know that part, because when I found out this, and I found this out years ago, I was like, what? And they said yes. They said Sandy Thurman used to own bulldogs, and I said bulldogs? No way, because I have a bulldog story of my own. But go ahead.
Well, I did. My wonderful ex-husband, Michael Clutter, and I started building bulldogs in 1977. I think we opened in 1978.
Wait, you were the original owners of Bulldog?
Oh yeah, we built it.
Oh no, I didn't know that. I thought you owned it at one point. I didn't know you. Okay.
We built it and together, and he owned it until I think 4 years ago. After 37 years, so we
Right.
owned bulldogs for 37 years.
Wow.
And while I technically didn't get any part of it in the divorce, we still both claim ownership of
Right.
it. And it was an extraordinary experience, but it was we set out to build, intentionally build a gay bar, because we had a lot of friends in the community, and I grew up with, in the gay community. My mother was a lawyer who represented a whole lot of gay folk in the city and around the country. So it was just a natural for us, and so we opened Bulldogs. It was not our first bar, but it was our first gay bar.
Okay. Very good. So now you and Dr. McCray go back a bazillion years. I'm not going to say how many. But you have also had several appointments of your own, and we're going to do your own interview, but I definitely wanted to talk about how you two particularly crossed over in the global space, right? Because that's how I know you two to have connected. So can you tell me a bit about y'all's crossover in global, and then your because it was global first, then domestic. Do I remember that right, or do I have it wrong?
No, well, I did domestic first. I was
Okay.
the executive director of Aid Atlanta, which is the largest aid service organization here in the city and in the Southeast, starting in 1988. So it was before we did global. I was doing local HIV and AIDS work, and then I really didn't focus on the global until I guess the late, late 1980s when we started talking about the explosion of HIV in Africa. And so it was on people's, minds, and people started talking about it, but I didn't sort of delve into it until I went to work at the White House for President Clinton in 1997 to be the AIDS czar.
Now
at the White
it was
House.
Patsy Fleming first, and then you. Do I have the order right, or do I have the order wrong?
No, so there was I can't remember the woman's name that preceded Patsy.
I can't remember.
There was someone.
Yeah, because it was you, Patsy, Judy Gerben. No, Judy was the CDC.
Yeah, so it was. There was a wonderful nurse, Christine Gebbe.
Yeah.
Christine
was
Gebbe,
the
that's
first
right.
one,
That's right.
and
yes.
then Patsy. They both stayed for a very brief period of time. And then I got recruited. I actually had a presidential appointment to the agency Information Agency, which is now part of the State Department. So I was already appointed by President Clinton to do something else, but the community could not come to consensus on someone they thought would be an effective aid czar. And so the only person they could reach consensus on was me.
Okay.
And I didn't want the job.
Right.
And I turned it down twice. And then President Clinton called me to his office and said, I want you to take this job. And it's just hard to tell him no.
Right.
Yes.
I mean,
Yeah.
a lot of women found that out, I guess. But I wasn't one of those. I want to be clear about that. But I did say yes and decided to leave my really fun job to go over to the White House to do the work. And then, we had an emerging epidemic in Africa that was just, mind-boggling. So we knew we had to do something, and we got busy on that pretty quickly. And that's how we met.
Okay, so tell me about that.
So I was minding my own business in tuberculosis, and when this money, when Sandy and the president gave this money to CDC, Helen Gale, who was the director of the HIV, the center at the time, it had HIV, STDs, etc. She asked me if I would come over and sort of get this program up and running, because it required collaboration with HRSA, with Peace Corps, with a number of different organizations, USAID and others. And then but because the money came from the White House, I actually went up to DC to meet Sandy to learn more about what they were looking for in terms of this initiative, and we just became friends. I mean, it was just so easy to work with
And
her.
you were both in Atlanta at the time too, right?
Well, yeah, but we met in DC for the first time.
Right.
Okay.
I mean, I knew of Eugene, but we didn't really know each other until we started working on this global AIDS program together.
Yeah, she pulled me from our TB world into HIV.
Well, we had to have somebody good. I mean, I'm not a dummy. Don't let the blonde hair fool you for a minute.
Right. So I want to talk about the global perspective, because I want to talk about the rural perspective. And I think that the global perspective gives us some insights into the rural perspective in the United States and vice versa. I think far too often people believe that, we export all of our information, learning, and skill sets to Africa. I actually think it's the reverse. I think things like telehealth, telemedicine, using cell phones, these sorts of things, using community health workers, using women and nurses and community in a response to healthcare is some of the stuff we actually imported, most of it, a lot of it from the continent. In this particular moment, one of the things that I'm seeing a lot is that folks don't understand the downstream effect of our funding cuts to USAID, right? And for me, what I'm seeing, because I do most of my work in rural America now, is that that's everything from, if we don't export food to other countries, farmers in the United States of America lose those contracts. So they can't now farm, feed their families, etc. I think the other thing that we kind of see about not being able to support global programs is that the domestic healthcare infrastructure now has lost a lot of its ability, in my opinion, to have those physicians, nurses, etc. do that work. Where do they go? Now we also have these federal cuts. We have a lot of our medical professionals that don't have work and don't have opportunity. Help me understand how you two see the downstream impact of our global losses or our global withdrawals.
Well, you want to start, and then I can.
Sure. Well, I think people, as you said, don't understand the impact that this will have on us. I mean, first of all, it hurts our reputation in the rest of the world when we've been really good partners for decades, and all of a sudden we decide without warning that we're going to back out of partnering and supporting life-saving activities in other places in the world that we know are resource constrained, and where we know there is unbelievable need and risk. So that's one thing. So it hurts our reputation, but it also hurts us because of what you were just talking about. We learn things. valuable lessons in the way that we are able to serve people in the rest of the world, quite frankly, more efficiently than we are able to do it here, more cost effectively, more efficiently, more creatively than we do in our own systems. And that's that learning that comes back to us from what we invest and what we learn in places like Africa and Asia and the other parts of the world. So I think and we have all these health professionals that we're losing when we have unbelievable need in this country, particularly in rural communities, and we're losing ground every day. So you mentioned that that the U.S. Work in rural communities and that in Africa and other poor countries in the South is very similar, and we need to learn from one another.
Yeah, and the one thing that I want to mention that nobody really thinks about as much, and it has a direct impact. It does have a direct impact on citizens here in the U.S. is the global health security aspect of it. The PEPFAR money, for example, helped establish an infrastructure that we built a lot of things on top of. So when we talk about disease transmission, outbreaks that may come from other parts of the world, the global program played an important role in helping us detect these things early and doing things that could mitigate these diseases coming to the U.S. All that infrastructure is going to be gone.
Right.
And I, as an infectious disease physician, is very concerned about the impact that's going to have in terms of how we are able to effectively deal with the next pandemic that's going to happen.
Right.
And it's going to happen. I say gonna because it's going to happen. And that infrastructure did not exist before the global
AIDS program.
the global AIDS program.
But and I guess my other thing is that I wonder how many people understand that, while some people look at it and say, well, why are we giving all of this money across the world? That kind of health diplomacy, global diplomacy, to me, it's like understanding that sort of diplomacy, somebody's going to fill that void, right? And I don't think the people that are going to fill that void are folks that necessarily have our best interest at heart. I think right. And I'm not going to name any nations that I think, but I think that they are waiting, they are chomping at the bit for us to get out of those spaces so that they can do everything from provide the infrastructure for healthcare to provide the infrastructure for oil and gas subsidies. And I think that I worry desperately that this mode of isolationism will cost us our health care and will cost us, as you have articulated, our image and standing around the world. When it comes to our ability to then provide health care, we see folks that are now going to probably open a bill in a few weeks, months, that is going to be 4 to 5 times. How do we provide health care for the most vulnerable in this country?
Well, I don't think we know that. I think you're right, and I don't think we know the answer to that yet. I mean, I think that we are putting ourselves in an incredibly difficult position, and it's so short-sighted because what we need to do, when we know when we reach people with life-saving information, when we do early intervention, all of those kinds of things that we need to do in rural communities and urban communities, frankly, saves us money on the other side, and saves us, productivity, and saves us having, wonderful folks, that are healthy and can go to work and so forth. And I see that, that we're seeing that in rural areas, and particularly with Medicaid cuts. And this is something I think is very short-sighted with the Congress these days as well, is that the majority of those folks are in the middle of the country. I mean, this isn't something that is sort of a political kind of conversation. This is the breadbasket of America that we're talking about. And folks are not going to have places to get treatment. They're not going to be able to put their parents in a nursing home. They're not going to be facilities for those kinds of things either. Yeah. And so I think we're really cutting off our nose to spite our face.
Yeah.
And so my data suggests we've done some work with a couple of consulting firms, and one of the things that we keep coming back to is that we believe that approximately there are 2,000 roughly 2,300 rural hospitals and clinics in the United States. And our predictive modeling says that 328 of those will close in the next 15 months. And so when we start to talk about proximity to access to healthcare, some of this will try to push folks into more urban centers to access that care. But then the question becomes, how do they get there? Folks say things like, well, use telehealth and telecare, but if you are in a broadband desert or what have you, you still can't access care. What do you think some of the solutions are for these clinic closures and these hospital closures, and how can we use technology to kind of fill some of these voids? Can we?
Yeah, I mean, one of the things that we did effectively in Africa is cell phone technology. And I know broadband is doing telehealth, you sort of need broadband, but you can also do telehealth by just having a telephone call. You don't necessarily have to see the person. Right. So I think almost everybody in the rural area will have a telephone. I mean, just like in Africa, there was no infrastructure for in-house phones, but everybody had a cell phone. So we've got to really think of innovative ways to take advantage of the technology that exists in that community. And sometimes we'll have to figure out what that is. Sometimes it's not necessarily a cell phone, but we don't have all the answers, but we've got to come up with solutions. And the way you get these solutions is really working with the communities to try and hear from them what they think might work best for them.
Well, and I think that you're absolutely right about the telephones, but I also think we're going to have to go back to some old school, very basic kinds of public health interventions. And it's going to require that we send people out into communities and that we partner with churches and we partner with the Rotary Club or the Lions Club or the Women's Club or whatever infrastructure we can find and that still exists in those rural communities. And that we use those homegrown institutions as our touchstone. And then we have a lot of the work that was pioneered in Africa is, we can go out and do health surveys. It's, very inexpensively. We can work with schools of public health and with these, local institutions to identify risks and to provide information to people about particularly diabetes and hypertension and some of the silent killers that we see that are so prevalent in poor areas and the country. So I think we have some interventions that we can deploy that are pretty cost effective that unfortunately is sad we haven't done before now, but we had learned a lot of that in doing our work in Africa.
Yeah.
Well, I think that one of the things, and I'm so grateful for you both taking time with me today, is that one of the things I keep thinking about is that we have a lot of people, many people who are suggesting that it's all about kind of getting back the old system. And I'm like, I don't think that that's our mission. I really believe our mission is we have to figure out very quickly how we develop a new system that is not as reliant on federal resources. And I don't mean just federal money and dollars. So, because one of the challenges, I'm going to ask you both about this, one of the big losses that we see in the federal government, not just at CDC, but in other places, is the lack of data access, right? The data collection that they did, the surveillance that they did. So how do we get academia, corporations to understand the value of data? Because we got to get it. I mean, if we don't know who we're talking about and where we're talking about them, I think then we're kind of shooting in the dark per se. But now the government is saying we're out of the data collection business.
Yeah, that's true. The federal government is saying that we're out of the data collection business, and I specifically say federal government because, let's not talk about the southern states for a minute.
Right.
Let's talk about the other states. I was just in Wisconsin, and this, they will continue. The state will continue, and the local health department will continue to collect data. It just won't be going to the federal level. Communities will still continue to collect data. Right. Organizations that are supporting communities will still continue to collect data because they understand how important data is for them to be able to do their work. At a federal level, we will know nothing about what's going on, but that's sort of going back to the way things used to be. And it's not a bad thing, but I do think that as we think about the future, the way forward, I think there's a way we can have national level data that doesn't rely on federal government.
I think that's true. I think that's true. And I think, in all of this, we also need to, there's a silver lining in this cloud. Because the system that we had at the federal system that we had wasn't working, and a lot of the state systems have not been working either, and nobody seemed to be able to do anything about that. After years of talking about it, I've been talking about this ever since I've been in public health. We all have, and so it's unfortunate that someone sort of dropped an atomic bomb on it. That was probably not the best way to start a renovation. Right. However, we have to look at the fact that we got rid of a lot of stuff that was bad with the stuff that was good. So building back, we have an opportunity to do it right and to go back to some of the basics. And when you look at why we lost some of our basic principles and ways of doing business, it was not because they didn't work, because they did. There were all kinds of reasons that people wanted to change it or control it or all this kind of stuff. And we don't have to do that now. So I think we do have to be creative. And of course, everyone's still in a little shock that we're in this place where we have to rebuild. But I think we need to seize the opportunity and be creative and go back to working in communities. That's what public health was in the first place. That's the public and public health.
And one of the things I kept saying is that, I brought together like 55 groups in April. And one of the things that I said to that meeting was that we had to do something that we had never done before. And that thing was that we independently and collectively had called this an HIV movement for over 40 years. That we hadn't been that, though. We frankly had been business competitors. I was trying to write a better grant than you. I was trying to get an appointment more so than you. I was trying to do this more so than you. But the truth of the matter was that this moment truly required that we be a movement in that we act together, in concert together. And that what I said also in that meeting was that if you were an enemy, you can be an enemy no more. If you were a competitor, you can be a competitor no more. Because I can't go back 30 years, 40 years, 10 years, 5 years, 2 years and say, this is what you did to me, and that's why I don't partner with you, or I don't work with you, or I don't talk to you, or I don't march with you, because this isn't about us. This is about all of the people that I think that we are here to serve and in service to. And I think that that's what the two of you, I think, represent so well. Which is, you both have your naysayers, you have your detractors, but if one thing that anybody cannot ever say about either one of you, and I'll say it, and I'll say it for the world, is that you haven't fought and stood on behalf of the people. So as you look down the road, what's the hope? I asked you, Dr. McCray, this, and I'm going to ask you this. I'm going to do more talking with you, but I want you to say, how do we get out of this? Because I know that we will, and it won't look like it used to look, but how do we get out of this? What's your little piece of hope?
Well, I think that we have to remember where we started in the beginning. And so in the beginning, before we had federal money or anything else, we were a movement. And people were standing together, and people came together from all walks of life and for all different reasons, some which we'll never know, to be supportive of one another in the early days. And what happened is we did get money, which we desperately needed, but then we turned from a movement into an industry. And so we were AIDS Inc. At that point in time. We weren't a movement anymore. We were AIDS Inc. And lots of people made a lot of money and all kinds of things sprung up. But now that that's going away, those people who showed up just because they wanted, for whatever reason, to get a position or start a business or have a contract or whatever else, are going away. What you see standing are some of the original people who were there for the right reasons in the beginning, and new people who are coming on board. And we're in a very different place than we were then, around issues of LGBTQ communities and women and people of color. All these things have changed dramatically since the beginning of the epidemic. And so we have a whole different group of people to choose from. Also, we have bigger health challenges. HIV is just one of them. I mean, we don't have a vaccine and we don't have a cure, but we got all kinds of treatment. And now we got people getting all kinds of other diseases. And we all got our, for folks who were HIV positive are now suffering from old people's diseases.
Right.
So we have to we have to come up with a whole new comprehensive approach to what was single focused in the beginning, which was finding treatment and being able to save people's lives. So we can do that now. We've got that. Now we have to figure out how you live into old age and how you, will deal with all these other issues. And I think that's encouraging, because now we're sort of like everybody else. I mean, we all have to figure out how I stay healthy, age together, all this complicated stuff in life. And I think that's a good thing.
Right. Well, they're telling me that I'm gonna wrap this up, and I just wanna thank you both for taking a moment with me here together, because I've also just really enjoyed watching your relationship. Watching you two across the room is no, really, I mean, watching you two across a room and dare I say, watching you two work a room is a master class. And I have been honored to be in some of those rooms and to watch and to learn. And so I want to thank you both for everything that you've done for our community. And so we're going to wrap up here. And again, thank you so much.
Thank you, ma'am.
Thank you.
Thank you, precious angel.